I love biohackers, but I cannot say that everybody who is then listening to that message they have should actually do it. It's nonsense. Like, it's fine that you feel better. It's great. Share also the non-successes. Very often it's about buy this and buy that. And if you do this, like, it's so commercial. So once biohacking goes from an NS1 approach to what the commercial space, and that's actually happened with Brian Johnson. I love Brian Johnson's messaging. Like, you show that, like, at the age of 42, you are looking miserable, and now you're looking different, and it seems also even that your emotional health is better. Great, good on you. But then it's turning around, and then it's into the mass markets, and then it's do not die and take the supplements with 100 ingredients or whatever it is for X amount, which is actually very likely not working. Stop it. And I don't want to be negative. My voice should be, biohackers out there, how can we utilize your extreme knowledge about physiology, about your body? How can we nurture that? How can you help us to design the trials and actually look at your data, build a registry? I would love to have a biohacker registry that we can learn what you do in these NS1 approaches. Maybe we can help with a couple of other tests and advice. And then getting that into trial designs, into multimodal trial designs where we can test different ingredients based on the ageotype, based on the phenotype of individuals. So if somebody is here listening and said, okay, this is now my mission, please be in contact.
One of the things you just said was we have a problem in the field. And I think you were there talking about your perception. A bit like I said in the introduction, that there is, among some people in the public, but also amongst our own profession, that longevity medicine is about hype and it's not evidence-based. How do you think that you can tackle that issue? I've actually never heard you be disparaging about clinics that don't do it in your way, which is very evidence-based. I've never heard you say that, but obviously it is causing an issue with the way healthy longevity medicine is viewed. So I wondered how you think you'll go about tackling that.
So luckily, that's not my way. I only have one. We have Chi Longevity, our private clinic. And of course, there are certain standards, but now we are writing the standards globally. That's most important. And that's bringing in the Health Longevity Medicine Society, which is a global peak organization for physicians and healthcare providers. But others are also welcome to join to really write the standards, to talk to the departments of health and say, this is what we can do. Do you want it? To be the partner of health insurers, to actually, do you want these kind of treatments? Who's going to pay? But also to have an educational standard. What should you actually know before calling yourself most of the times, longevity specialist? You don't even have to be a physician. It's fine. Like you can be a longevity nurse, but what is a longevity nurse? What is a longevity physiotherapist? I have no understanding. I don't know. It's not regulated. It should not be used. So even what is a longevity clinic? And you see very often it's longevity. I always call it a healthy longevity clinic because it should not just be about the time, but the quality we are getting out of it. It's a huge problem. There are many, now it's my view, or even the HLMS views, clinics who are opening, who could actually cut the hair and people will feel better, and they prolonged individuals' happiness and life even in certain circumstances. But that's not the essence. And then I'm referring back to the definition. It's antagonizing the aging process. And you don't do that by cutting your toenails or cutting your hair. So really understanding what the fundamental biology of aging is and bringing that into clinical practice. So we wrote last summer the standard for the Department of Health in Abu Dhabi. They signed off a couple of months later. They are the first clinics being certified. We are reviewing at the moment the standard. We are bringing educational standards in. And while having a Department of Health really signing it off and say, we really want to acknowledge it. because we want to separate us from the snake oil. That's so important. And that was such a sort of enzymatic function that now other departments of health are knocking on the door and say, what do we do with it? We are really realizing it might be a problem. We actually want to make sure that we don't have the huge side effects of treatments as you gave in the introduction, stem cells, peptides, etc., hugely not regulated. How do we make sure that we grow the next generation of medicine in a way which is fundamentally different, but which is ethical and which is evidence-based?
Yeah.
And
you talked about growing the profession, so growing your workforce to deliver healthy longevity medicine. I wondered whether you can speak to, I think for primary care physicians for all of us that have been trained in traditional evidence-based medicine as being the gold standard, one of the tensions is working in a space in which the evidence is evolving. And we see it in women's health as well, because there's not very much evidence there either for different reasons. But that tension between knowing that, okay, evidence-based medicine on a population level is the standard. And then after that, what we usually do is then do our experimentation with patients, do our N equals 1 and say, right, well, let's see now if this works for you. And that is the way that we should be doing it. And how that fits in with an evolving evidence base where perhaps patients are coming to you saying, look, I've heard of this and I know that the population-based evidence is not there, but I want to try it. And that tension that you feel as a clinician going, oh, well, I don't know, and I don't know much about it, and this is not the way I've been taught to do it. Because I wonder whether that will be a bit of a barrier to getting the workforce that you need behind you. And I just wondered how you approach that.
So first of all, I think that we absolutely get the workforce behind us because everybody is very interested, because I think there is such a big market and everybody is asking. So, and everybody also feels a little bit their internal tension, their gut feeling, I just need to learn more and I need to be better before providing the care. But you're absolutely right. There are very vocal patient groups who just heard, because of a podcast, very dangerous podcast.
We'll try and make this one not so dangerous. That's why I've got you here. Try and tell the nuance and the truth.
Because they have heard to do something and they think you can deliver it. I think 100 years ago, this is how many revolutions in medicine were actually occurring, because you were self-experimenting. But most of the times, the physicians were self-experimenting. Penicillin, for example, is a result. And now we have this huge vocal group of especially middle-aged individuals who see that something is happening. They have certain symptoms and they want their relief. And longevity medicine is out there, so solve it. So this big consumer ask with limited knowledge, with lots of noise, and the noise are the podcasts, the noise are the socials. How can you digest it to really, as a physician or a healthcare provider, make the choice to do certain therapies? It's a huge dilemma, because nobody is going to train you to make that decision. I neither did the decision. I haven't had in my medical school history any lecture of a patient want this, you don't know what it is, like it was not discussed. So how do you really bring then your ethical standards to it? And I would say, train yourself and make that decision how far you want to go. If the physician does not know, don't do it. Like if you know that this is experimental, the client or the patients know it's experimental, then you both know the risks. I shouldn't say that, but do it if it's a shared decision making. And it's the right of the individual then to get that care, in my view. However, do I think this is the standard of modern medicine in 2025? And I would say 10 times no. This should not be the case. Why are physicians with a shared decision making, both know what it is, both know have experience, at least the physician in doing it, why should be somebody in that awkward position to do it if we have modern research institutions where we could actually get the answer what to do within a year time? And I just do not understand it. I really do not understand why the movement of experimental designs are not going into the academia of academic research institutes to actually test it.
Is it about funding and time and recruitment? Is it just too difficult?
No, of course, there's always, we say it's about funding. It's absolutely no problem to recruit. I can tell you this morning when I came at 8:00, everybody was lining up in front of our clinical trials center with a smile. I want to be first. I want to be first. It's really lovely to see that population understand it to be in trials. But there are two problems. The first problem is if there is a consumer who wants something, who is paying for it, why would you actually test if it works? Because consumer need is there and it seems that they're satisfied. Secondly, is academia is quite, I would say also our trial designs out-fashioned.
Yeah.
We are very slow. We are very hard to convince.
Yes.
And it seems that we are very difficult.
Yes.
And
I do. And I think that's what patients are getting frustrated by. And I think that then leads to this, the social media and the podcast of people who go, actually, no, let's move this discussion on.
Let's do it.
Yeah, let's just do it. Exactly.
I would really, if you want to have a trial with endometriosis, if we could just enable it with crowdfunding, I think you would fund such a trial to enable individuals to really contribute to the field, that the next woman in 3 years' time really knows what to choose, not asking you, can you prescribe me rapamycin, which dose? I don't know, never did it.
Yeah.
4 milligrams, 6 milligrams per day, 1 milligram
per week,
or per week.
Who knows? Yeah.
Like, what do you do? How do you measure the success? When should the success be measured?
Yeah.
Or even if experimentally it's being done, include all the data to have a learning. And also that's not done. So academia has to get their act together. Yes, to just be faster, to act as a partner in crime with the crowd who wants something and with the physicians who are now at the edge, oh, do I do it or don't I do it? But also adapting our methodologies. And as one trials can be good for certain indications, but the placebo design trial, so you get it or you don't get it, I think is preferable still, but doesn't matter. And enable the crowd to have a voice.
Yeah.
And that's so important. Like if women can stand up and say, we want this, then we can have a dialogue. How can we make it work? And really looking at the strengths. And it's not only financially, but organizationally, how do we recruit? And this is so important that very often, especially not in the longevity space, we don't have patient organizations, because you are not a patient when you are aging.
Exactly.
Like you are just aging. Of an aging organization. It's very negative, so don't use it. A client organization also doesn't sound good. So we don't have that voice. The only voice we have, and that's very, very, I think, important to mention, are these biohackers, which is great. Like, I love biohackers, but don't be so noisy.
Yeah.
Yes, and
I wondered whether that was the case. I wondered whether, because as I said, I've never heard you be disparaging about biohackers or people like that, and I wondered whether it was because you just felt actually at least they're getting the message out there, and then you can come in and you can reshape the narrative in the way that in the evidence-based way that you want to. Is that the case?
It's absolutely. I love biohackers, but I cannot say that everybody who is then listening to that message they have should actually do it. It's nonsense. Like, it's fine that you feel better. It's great. Share also the non-successes. Very often it's about buy this and buy that. And if you do this, like, it's so commercial. So once biohacking goes from an NS1 approach to what the commercial space, and that's actually happened with Brian Johnson. I love Brian Johnson's messaging. Like, you show that, like, at the age of 42, you are looking miserable. And now you're looking different. And it seems also even that your emotional health is better. Great. Good on you. But then it's turning around, and then it's into the mass markets, and then it's do not die and take the supplements with 100 ingredients or whatever it is for X amount, which is actually very likely not working. Stop it.
Yes.
So how do we, and I don't want to be negative, my voice should be, biohackers out there, how can we utilize your extreme knowledge about physiology, about your body? How can we nurture that? How can you help us to design the trials and actually look at your data, build a registry? I would love to have a biohacker registry that we can learn what you do in these 1S1 approaches. Maybe we can help with a couple of other tests and advice. And then getting that into trial designs, into multimodal trial designs where we can test different ingredients based on the ageotype, based on the phenotype of individuals.
Yeah.
And then I think it will come out of that academia is slow. We need the patient voice, not only the biohackers, but also the USME. So if somebody is here listening and said, okay, this is now my mission, please be in contact. And we are so grateful that we have an alliance with the Singapore Patient Alliance. We signed the MOU a couple of weeks ago and are working with them. And while integrating patient organizations, so the patient organization for dementia, for women's health, that's so powerful.
Absolutely.
Because it's not just when you have the first disease that you are excluded from being healthy. And very often this is also the narrative.
Right.
Like, no, I can't be in your trials because I have hypertension, I had a stroke, and I had endometriosis 30 years ago. Come, you're welcome. We are all aging. So there should not be the exclusiveness of the healthiest to polish that to be even more healthy. No, it's for everybody with the diseases. And that's the reason why we are so happy to work with the existing patient organizations in Singapore.
Amazing.